I want to talk about intimidation for a second. So let's say it's a little over 100 years ago, and you're invited to present at a physics conference somewhere in Europe on the theory of relativity. And you're all excited. You're going to take the podium. You've been all prepared. And then you look, and this guy is sitting in the second row of the audience. You would be somewhat intimidated. So then let's say you're asked to talk about knowledge transfer in pediatric pain. And you look in the second row, and this person is sitting there. You'd be a little bit intimidated. Hi, Bonnie. I think I'm going to call you Al from now on. So let's look at the models that we have. And I'm going to take us a very different kind of perspective on this than Bonnie did, although certainly I'm sure we're going to overlap. So this is a scene from a famous movie that some of you may recognize, where the guy says, badges. This was a Humphrey Bogart movie, and he was out in the middle of nowhere, and he's confronted by these guys who are the federales, and the guy claims he's a federal official, and he says, let me see your badge, and there's the line, actually they never really say badges, we don't need no stinking badges, that was from Blazing Saddles, if we're going to be correct. But here are two models of physicians that are portrayed to us. For those of you not old enough to remember, Marcus Welby was Robert Young, who was also Father Knows Best. And he's this very kind, grandfatherly sort of person who knows all of the details of each of his patients' lives. He's incredibly caring. And then he brings his skill and knowledge of medicine to that relationship to work with that individual. The other is Dr. House, who most people would say was a flaming irritant. He was brash, he was obnoxious, but he was able to use his brain and figure out everything in his head so that he always had the capital T truth. So what do these two guys have in common? Practice guidelines. We don't need no stinking practice guidelines. So let's look at the whole issue of clinical versus actuarial decision making. And I think this is, Bonnie took it back to way back, hundreds of years with scurvy, but I'm going to get us a little bit closer. So Paul Meehl was a psychologist, and from around 1954 onward, he started to take an interest in what it meant to consult. And in essence, if you are a provider, a physician, a psychologist, etc., you're a consultant. You're being tapped for your knowledge to put things together. And when he looked at data interpretation, he saw that there's two ways to do it. One way is the Marcus Welby House way, which is you gather whatever information you think is important, you put it together in your head, and you make a recommendation. And the other is actuarial, which is where you use statistical models to make a decision. And the decision is made only based on empirical relationships that are demonstrated. And then, of course, there's the possibility of a combined approach, which is you use an actuarial model to the degree that you think it is appropriate. And then beyond that, you start using your own judgment. So if clinical judgment and actuarial decisions perfectly line up and they're the same, everything's hunky-dory. But if they're not the same, then you have an issue. And what Meehl spent many, many years doing was a lot of research showing that the actuarial approach is consistently superior to the clinical decision-making. And one of the issues that he found is that clinicians will often say, yeah, but this model doesn't apply. I have clinical knowledge that should supersede it. And sometimes, obviously, that's true. And the data would show that that is very often incorrect, that you give yourself more credit for what you think are the exceptions than they actually are. So why is actuarial decision making better? So the first is that it's reliable. Any two individuals could be in the same situation, presented with the same data, and they'll draw the same conclusion. The second is that mathematical models are good at looking at the variables that do predict and not focusing on those who don't. Dr. Groupman, who's here in Boston, wrote a book about how doctors think. And if you haven't read it, I encourage you to do so. But one of the things he talks about in there is a self-fulfilling prophecy. That once you get an idea that the patient has a certain diagnosis, you then gather the data to fit with that diagnosis and systematically ignore things that do not fit with that diagnosis. And the other is that clinicians have a skewed view of the world. So when I was doing a lot of work in pediatric oncology, every time I would encounter a kid with 102 fever, I'm thinking, oh, this could be leukemia, when in fact the probability that that's the case is exceedingly low. So if we have this overwhelming evidence for why actuarial models are better, why the resistance? Why don't you see the behavior change? So Bonnie got into some of these issues, and again, I think I'm going to hit on them slightly differently. So the first is obviously people need to be aware that there's an actuarial model out there that they could use. But even once they're aware of it, they'll often dismiss it. Like, my tendency is to do things this way. You're telling me something brand new. I'm more comfortable doing it the old way. Oftentimes you believe that group statistics don't apply to individuals, which is true. So if you have some study that you're doing on cancer treatment, and you know that for 85% of the patients with a given diagnosis, this drug will work, that's great, but you don't know how it will work in that given individual. And people tend to focus on that and say, well, it just doesn't apply. And certainly, we continue to have the false impression that our skills to gather information on our own are superior. So there's also people who feel like clinical research is not sufficient, that clinical research doesn't necessarily apply. And I think to some degree that's valid. So if you're looking at randomized clinical trials for various drugs, if you look at how the safety and efficacy of those drugs are studied in order to get FDA approval, that's almost never how the drugs are used in the real world. And so you could say, well, wait a minute. Just because you've got this study that has high internal validity, how well does it really apply to my situation? Another criticism, and I put this one in red, by the way, the stuff in red is what I think is important. You probably figured that out. We don't really know if evidence-based medicine is effective. We think it is. We think that it makes sense that you apply evidence and then you get better outcomes. But as you will hear as I move forward with this talk, not necessarily been demonstrated. Evidence-based medicine is deemed to be more clinician-centric rather than patient-focused. So again, going back to the whole House or Marcus Welby model, what made them so effective in the public's eyes is that they focused on that individual patient. And studies have shown that pediatricians specifically, with regard to their use of clinical practice guidelines, feel that it ill affects their clinical judgment, it doesn't match with their practice styles, and there are little data to show that it actually reduces healthcare costs as it's presumed to do. So if you're going to get down to this debate about whether or not clinical practice guidelines and actuarial methods are superior, you need to answer two questions. And when you start to look at the literature, this is where studies go. Once a guideline is generated, how often is it implemented? Because if you generate a guideline and it's not implemented, who cares? The second question is, if a guideline is implemented, does it have any impact on a desired outcome? Do you get better clinical outcomes? Do you impact cost in a positive way? Are patients more satisfied? And as you go forward, again, looking at studies, there's different levels of focus that one could get into. So the most common guidelines that you'll come across is within an organization. So we have this emergency department. In our emergency department, we decided to implement a guideline for how to evaluate blank, and we did a study on it. Sometimes you'll come across studies that are regional. So I think Ann mentioned before the group in Ohio of 6 children's hospitals that got together to look at outcomes and various guidelines. So if they published a study, that would be an example of regional. There are federal guidelines, there are national organization guidelines. The American Academy of Pediatrics has a guideline on immunization or a guideline on breastfeeding, etc. And slowly, but surely, and more in Europe than in the Western Hemisphere, there are international efforts where people from different countries will get together and try to look at how some of these guidelines are implemented. The other questions that you have to answer in this process is who generated the guidelines? Was it just a group of people who sat around a table and said, I think we should do it this way? Was it some national organization? What were the processes? How much was evidence invoked versus, quote, expert opinion? And I put expert in quotes because who defines who's an expert in a given area? More and more what you're finding in the literature is encouragement for including patients and families when you're developing guidelines. Since they're the consumer, shouldn't they have some significant say over the contents of what goes in it? Then once you've developed the guideline, how do you disseminate it? Do you just publish your little brochure and hope that people will write to you and ask for your brochure? Do you publish it in a journal? Do you publish it in multiple places? I noticed last year when the CDC guidelines came out on opioid usage, that was published in a few different places all at the same time. What accountability is there? So if you say in your institution, okay, in our emergency department, here's the guideline for the evaluation and treatment of kid coming in wheezing, how do you know who's doing it and who's not? What's the implication if they do it or they don't do it? Is there anybody monitoring it? Are there any rewards or punishers, carrots or sticks? And then, do you evaluate the impact? So you decide you're going to implement this new thing in your emergency room. So what? What happens then? So when you look at the studies that are out there on these things, by far and away, the majority of them are retrospective chart reviews. So basically, you're going to implement some new practice guideline in your hospital, so you look at data from the year before you implemented the guideline, you wait like 6 months until the guideline's in, and then you do another year after, and you compare results. Obviously, that design has a lot of flaws in it, including the major one that there are plenty of other uncontrolled variables. There are a lot of confounds. You're not necessarily getting a clean data set because you didn't design the study ahead of time, etc. Excuse me. Occasionally, you'll find a randomly controlled study where there'll be the institution of a guideline and then there'll be some control group to study the impact of that guidelines. Many of the studies are surveys. So somebody will come out with a guideline and then they'll do a survey of the providers and asking them about their implementation of the guideline. And obviously self-perceptions and behavior are not the same thing. People always overestimate what they think they're doing compared to what they actually do. When you're looking at these studies, it's interesting to look at how big a scale was the study done. Was this a single site with 20 patients in each group, or was this like a major endeavor looking at some national study? The two things I noticed reading these studies that I found acutely irritating, and for those of you who know me or have ever been on the receiving end of one of my journal reviews, if you talk about non-significant trends, I get a little bit irritated because that's a stupid thing to say. If you arbitrarily define something as being clinically significant at 0.05, you can't then say, well, it's 0.07 and so it's a significant trend. First of all, it's not significant. And second of all, you have no business saying that because it's not significant. Yet when you read these reports, there's a lot of these non-significant trends that you see. And the other is that if you read the results section of some of these studies, and then you read the discussion section presents a way rosier outcome than the results section. It's kind of like these people are rooting for these things to have some meaning, even if they don't necessarily. So let me give you a few examples. Here's one that I thought was relatively good from about 3 years ago. So this is the kind of example that I'm talking about where these guys and gals, I don't like sexist language, so I had to add that. They looked at bronchiolitis in infants in the emergency room, and they implemented their clinical practice guideline. And what they showed is that prior to comparing the data from prior to and after they implemented the guidelines, things like chest x-rays went down, RSV testing went down, ED length of stay, albuterol use. They looked at cost, which was a nice thing, right? They saved some money. And then they looked at where there were not changes, including the areas where they were hoping there wouldn't be changes. And some of the areas where they hoped there would be changes, but there weren't, like admission rates, for example. A multi-site study. This was one where the Infectious Disease Society of America came up with a clinical practice guideline specifically looking at neutropenic patients with cancer. So this was through a relatively large database looking at 600 hospitals. It was over a well-defined period with a solid N, etc. And the guideline-based antibiotics were administered 79% of the time, which overall is reasonably good. The hospitals that had higher volumes and did more treatment tended to be those that were more adherent to the guidelines. And very importantly, there was a decrease in things like discharge to a nursing facility and death. So if you're not having people die as a function of your guideline, I'd say that's a pretty good outcome. Here's a study that was done in Europe, looking at community-acquired pneumonia. So the other thing you're going to find when you get into this literature is there are certain clinical entities that tend to get focus. And I have no idea, and it may be my naivete that I don't understand the issues well enough, but community-acquired pneumonia was a really popular one. The other one that you're going to hear about is syncope, and why that one is such a popular one. If anybody could tell me, I would be helpful, but they're the ones that pop up. So if you look at community-acquired pneumonia, it's an expensive proposition. And the cost of treating it if you hospitalize somebody is 15 times greater than doing it on an outpatient basis. And so what you really want to show is that you don't have increased mortality, you would treat the situation appropriately, that length of stay goes down, and you're looking for processes that could affect these. So with the study that was done, guideline to adherence showed a change in cost with no change in outcomes. There was a decrease in admissions with adhering to the guidelines with no increase in adverse effects. So on the outpatient side, that's a good thing. And then if you look at the inpatient side, what you find is that they were saving 20 lives per year on the inpatient side among 17,000 patients. That was an effect of using these guidelines, and that the readmission rate was lower. So the key points is that mortality rates went down, readmission rates went down, costs went down, and you saved more lives. So I would say that's a good guideline. Wouldn't you? Especially if you're one of those 20 people. So then I started looking at guidelines in psychiatry. So this is an area that's obviously way less defined than community-acquired pneumonia. I think if you're talking about diagnosing and treating pneumonia, it's a little bit clearer than if you're treating psychiatric symptoms. So I came across a meta-analysis looking at various studies. There was 85 studies that were included in this, looking at guidelines for psychiatric. And what you could just see here looking over it is that many studies showed no benefits to the guideline. Impact on patients was, if there was any, it wasn't very durable. And the author ultimately concluded that there's little or no benefit to introducing psychiatric guidelines in either primary care or psychiatric practices. And maybe it's just because I'm a psychologist and I think I understand psychological issues better, but I kind of get that, right? Like if somebody comes in with anxiety and you go, well, here's my treatment package, this is what we do for everybody diagnosed with anxiety, I think there's going to be a lot more variability in that group than there would be in others. So here's a national guideline that came out on rectal cancer, and this is one that showed, I think, an outcome that wasn't very good, and that is that in 5 years after the guideline was implemented, there were no real improvements that were shown. And so again, if you really tore into this, you'd want to know, well, who generated these guidelines? How were they disseminated? What was there in terms of accountability? So then let's move away from generic and get a little bit more specific and look at what's out there in terms of pediatrics. Pardon me a sec, I'm going to stick another cough drop in my mouth so that I don't hack into the microphone.
You want some water?
No thanks. But you're good at that. You did that for me 2 other times at conferences. You brought me water. So thanks. So here's a focus on syncope in pediatrics. And so this was, the first one's a single site study where kids show up who are passing out, etc. And so often what happens if somebody has syncope is they get sent to cardiology. Cardiology does $1 million workup. It's rarely indicated. So when they instituted these guidelines in the single institutions, they showed a decrease in kids going for echoes, a decrease in hospital admissions, generally a decrease in unnecessary tests, and then they demonstrated what one could do, which is take a detailed history, do a physical exam. If you do that well, for the majority of cases, an echocardiogram does very, very little to add to the picture. Then there was a regional effort for syncope, and this one was done across institutions with a specific methodology. Bonnie, can you remind me what SCAM stands for? It's in the title and I can't read it. Standard Clinical Assessment and Management Plans. That's SCAMP. So you're basically standardizing the approach. And so again, what they find here is that basically if you use a simple scoring system and you determine the critical aspects of syncope, you don't need $1 million workup. Pediatric guidelines, some more good examples. Again, we're back to community-acquired pneumonia. This article focused a lot on the PDCA cycle. So for those of us who are into performance improvement, plan, do, study, act. Yeah, but it was still PDCA when they published the paper. Yeah. So what they showed here, once again, is that there were some real changes, especially amongst the residents, where prescribing appropriate antibiotics shifted dramatically in the direction you wanted to. I alluded to studies done within various groups, like the group in Ohio. One of the things they tackled amongst those 6 hospitals was looking at tapering babies off of opioids who had neonatal abstinence syndrome. And what they showed was very nice results when everybody collaborated and studied it and did it the same way, where the duration of opioid treatment went down, the length of hospital stay went down, the use of adjunctive drugs to help with withdrawal went down, and the outcomes were sustained across the institutions. Here's some more good examples. This is a single site study looking at appendectomy. And what they were trying to do was reduce costs and still not miss the boat on failing to appreciate when somebody's appendix needed to come out. And what they showed pre and post implementation was exactly what they wanted, which was a decrease in CT scans, increased use of ultrasound. What happened?
I had the same, the Wi-Fi seems to pick out.
Are we okay? We're back? Okay. Increased number of cases that didn't go for any images at all, and as you'll see, no change in the appendectomy rate. Gastroenteritis, the study that was done where they implemented a guideline to treat that, and you can see that by keeping people out of the hospital and approaching that, far less cost. Here's some problems with a pediatric guideline. This was an interesting one. This was one where in the discussion section you would have thought that this guideline was really good. So they do this thing with acute wrist injury in 4 different hospitals where they want to standardize it. And they come up with these 6 variables to study. So if you look at that sensitivity and specificity, I don't know where you sit, but I wouldn't want my kid to be evaluated with a guideline where the specificity was that low. And in fact, in so doing, about 4% of the fractures would have been missed if they used this guideline. So what that means is a kid shows up, is evaluated because they fell on their wrist, and 4 out of 100 of them, you're going to send them home without appropriate treatment. Bad guideline. Yet they didn't think so. Okay, so we've done looking at how guidelines are studied in general. We've looked a little bit about some of the generic issues with, yeah, Bill?
So my guess is a lot of those fractures probably don't need to be treated at all. So sending home 4 out of 100 wouldn't be actually so bad. But
thanks, ED Doc.
anytime.
Unless it's your kid.
Yeah. He probably had plenty of fractures that never got treated.
Okay. So let's talk a little bit about some of the studies that have been done looking specifically at clinical practice guidelines for pain. And the first thing that I found very, very interesting when I got into this literature is that a fair amount of it's been done in Europe by physical therapists. So they came up with a physical therapy manual, and by using manualized physical therapy strategies in general, you find that there's better improvement in functioning, decrease in costs. There's a guideline with almost 1,200 patients for low back pain. So the first thing that you'll notice is that the guideline was only adhered to about 40% of the time, but even with that, the patients who got the guideline had fewer visits, more improvement in disability, better success with PT. Training and clinician feedback does not necessarily improve some of the outcomes, but in red what you'll see there is that if you had more general chronic musculoskeletal pain, outcomes did not improve. So the more specific the issue you're dealing with, the better. In 1994, here in this country, a federal guideline came out on low back pain. And so we go into a database, we study people for 3 years before the guideline's implemented and 3 years after the guideline is implemented. And what they focused on a lot was what drugs were used, whether or not people went for x-rays and PT referrals. So I just want you to pause for a minute and think about our current views of what's optimal for chronic pain. And what you see here is people used acetaminophen a little bit more, not really a big difference. NSAIDs stayed about the same. Muscle relaxants dropped, which was good. Radiography went up. I'm not sure if that's good or bad. And PT referrals went down. So that's not necessarily where we want to be in terms of how we would treat chronic pain at this point. There have been guidelines that have come out through the cancer care networks to treat cancer pain, and what you find when you review those is that generally speaking adherence to the guidelines is poor. Cancer patients continue to be inadequately treated for their pain, And as soon as somebody is seen as opioid tolerant, then treatment is even worse. Here's another study that is through the National Ambulatory Medical Care Survey data. Survey data? Should be survey, sorry. And so this was a very large study. When you look at that N, I don't know that I've seen too many studies that have that many patients, but it was over a 7-year period with people going to primary care. And what you find is that most of the care that went on during that period was not only inconsistent with the guidelines, it was oftentimes opposite. And if you look more at the breakdown here, I put a couple of things in red. So what we know is optimal for people with chronic pain of this ilk is a rehabilitation approach, where you send them for mental health treatment, you send them for physical therapy, and you avoid opioids. And if you look at the numbers in red, clearly that's not what was happening. Am I boring you, or is this like keeping your interest? Because I just have like a whole bunch of these studies, and I found them interesting, but are we all right? Okay. So here's a survey of physicians looking at compliance with an evidence-based approach to guidelines. I stayed away in general from surveys when I put this talk together because I don't believe the results. But this just generally showed that generally speaking, if you have back pain, if you have something more specific like sciatic pain, people are more likely to pay attention. Again, another survey showing that when you instituted guidelines between January 1999 and December 2010 for back and neck pain, over 440 million visits, you had acetaminophen and NSAID use go down, opioid use went up, PT referrals stayed the same, referrals to other physicians went up a bit, and again they focus on radiographs and MRI.
Is that the problem with the guideline? I mean, I'm assuming the guideline didn't suggest opioid use increase. So or is that the problem with non-compliance?
So I don't know is the short answer. I didn't actually read the details of all of these guidelines, but Dan, you would potentially know this. Were there guidelines in the late 90s into the early 2000s for chronic back pain that did recommend opioids?
Maybe not in that exact year, but one of the couple of guidelines that are widely cited was on the use of opioids for chronic non-cancer pain.
Wait, let me give you this, because you have words of wisdom.
So, Gary was just asking about what about guidelines in the late 1990s or so, but I can't assign a guideline exactly to each year, but there were several guidelines on the treatment of low back pain. Some of them were developed through American Pain Society, American Academy of Pain Medicine, and actually those guidelines did recommend for a subset of patients that opioids could be used and people ought to be tracked carefully and so on. So there were guidelines that did include opioids in that wave of guidelines in the 90s and 2000s.
Good, thanks. And were you part of the committees that put them together?
Actually, no.
Okay.
Not those particular ones.
All right, so moving forward, here's some more on acute back pain. And this was a study published in 2004, so we're still in that era before people were more enlightened. So this was trying to change some of the practices in the UK, and what they found is that there were no differences in terms of referring for radiographic studies. A sickness certificate is basically the same thing as filling out SSI forms for disability. No changes in prescribing opioids and no changes in secondary referrals. So this is not necessarily pain, but it's one that I found interesting. for those of you who aren't neck deep in the opioid controversy, I will tell you that the state of Washington has been on the forefront of trying to curb opioids. There was a discovery made about the number of people going through labor and industry who are on opioids who were dying. And so in 2007, the state issued for the first time its opioid dosing guidelines for non-cancer chronic pain. And so there was a fairly decent end. And when you look at these outcomes when the state implements some of these things, you can get some fairly decent results. So the opioid use went down in terms of the number of people on it. The use of high-dose opioids, defined as greater than 120 milligrams of morphine per day, dropped 35%. And so the only focus of this paper, and given the group in Washington, I love them dearly, they only focused on opioid prescribing. There was absolutely nothing in the paper about appropriate pain treatment that might have been offered instead. Okay, so now we've done generic issues, we've done pediatric issues, we've done general pain issues. Now let's get into pediatric pain issues. So here's a study that was published on the Vienna Protocol for Neonatal Pain and Sedation in NICUs. They defined specific strategies for treating pain and discomfort. What they got for results in their study that they actually wanted to have happen was increased opioid dosing. Again, keep in mind this is based on the data of completely inadequate pain treatment in the NICU. So what they would want to see is more appropriate use of medication. So they got an increase in opioid dosing, an increase in other pharmacologic interventions. Staff was far more satisfied when kids' pain was treated well, and some of the problematic outcomes did not change. So there was no greater time on mechanical ventilation or adverse outcomes, and unfortunately, length of stay stayed the same. This is a study on pediatric postoperative pain, and I'm going to talk about this one in a little bit more detail because it was our study. So we had a tragedy at Seattle Children's. I will tell you about it because it was public. So I started my job as the director of pain medicine on March 1st, 2009. On March 5th, 2009, you got that? Day 5 on the job. A 16-year-old boy with autism goes in for a dental procedure on a Friday afternoon. And after the dental procedure, the dental resident prescribed acetaminophen with codeine as his post-op pain treatment. That was before I got them to take codeine off the formulary. So the mom says, well, my son is autistic. He doesn't do well at all with swallowing pills or liquids. Isn't there some other way you could give him pain management? Isn't there some kind of patch that could be used? So the dental resident looks in the formulary and notices that there's fentanyl patches. And they come in 5 different sizes, 12.5 mics, 25, 50, 75, and 100. And he goes, well, this is a children's hospital, and this kid's basically adult size, so let's give him a 100 mic fentanyl patch to manage his pain. You could imagine the outcome. He was found dead in his bed the next morning. And so there was this huge brouhaha. Oh my God, you know, we killed the kid, this is terrible, we've got to do something about how we address pain, especially for ambulatory procedures. And so, being one to seize opportunity, I'm all of a sudden sitting in meetings with like the CEO, the CMO, etc. And I said, look, you can completely eliminate any adverse effects from opioids if you never use them. But you got to use them to treat pain. So why don't we use this as an opportunity to improve how we evaluate and treat pain and not just look at opioid safety? And so Seattle Children's prided themselves on this Toyota model, the lean model for performance improvement. And so we got resources from the performance improvement group, and we went to work on this issue. So what we focused on were strategies to discuss pain treatment prior to surgery. So the first problem on this Friday afternoon was mom raised this issue as they were going out the door. So if somebody had discussed the situation ahead of time, that problem might have been eliminated. So we set it up so that when you go for your outpatient visit where the surgeon decides that your child needs surgery, that's when the discussion about postoperative pain management occurs. Once you have that discussion, it's then recorded in the EMR. And we even set it up so that the outpatient pharmacy had those drugs waiting for the family when surgery was complete. That didn't happen 100% of the time, which is why I didn't put it in here. Our outcomes show that parents perceived that pain was adequately discussed. And we had used the post-surgical behavior checklist that the group in Canada came up with, Pat McGrath and his group, for parents to take home and evaluate their kids' pain so that they could make objective decisions about treating pain. And not part of the performance improvement endeavor, but something that we also did that turned out to be a brilliant move, was we standardized the pain treatment based on evidence. So we looked at what the prescribing patterns were of the 11 general surgeons, and I'll tell you about what we did more specifically in a second, prior to and then after we did this. So this was, we decided to pick a single surgical procedure. So what you heard Stefan say before is that you start small and you get a success. You learn from it and then you generalize it to something else. So we started out with hernia repair with general surgeons. And it was umbilical as well as inguinal hernia. So I don't know how well you can see this, this graph, but this is the pre-post. I'm wandering. This was the pre-post about opioid usage. So what you see on this line was the protocol that we used, which was you alternate acetaminophen and ibuprofen, and you have oxycodone only for breakthrough pain. So what you could see prior to our intervention is that things were all over the place. Everybody did things completely differently, and even within providers, like if you look at some of these, like provider 2 here, every time that person did surgery, it seems they were using a different pain treatment protocol. This was after the intervention, and what you could see is that almost the majority of the time people were doing it the same way. And if you look even at this one, you'll notice that there are still a couple, like this person is never using the standardized protocol. Some of these people are still using various and sundry other methods. And that's where I was beating my head against the wall with the issue of accountability. Like I sit down with the chief of surgery and I say, you know, we're looking at these data and you've got 2 surgeons who are out of line. And he looks at me and he goes, Gary, I don't need your data. I can tell you exactly who those surgeons are, and we're not going to get very far with them. And I'm thinking, you're the chief of surgery. You could do something about this. So the smart thing that we did with this whole thing is the process owner, the person who was steering this boat, was not a pain medicine person, it was a general surgeon. And the deal I made with him, Jeff Avancino's his name, was you work on this with us and we'll get you a publication. Because he wanted to become an associate professor, and this was in pediatrics. Okay? A lot of input from the pain medicine team on putting this together. We got all of the relevant stakeholders in the room. So all of the people in the surgical area, the people, and it was all ambulatory surgery. So anybody who would touch these kids, people from the pharmacy, from the clinic, etc., were part of the process. We standardized how people assess their kids' pain. So that's important because oftentimes you send parents home with a bunch of drugs and they're like, well, when do I use these? How do I know how much pain my kid should be in before I give them an oxycodone? And when you say, here's a behavioral scale, if the kid scores higher than 6, you should give them an oxycodone. Parents found that incredibly helpful. I put data, because the only way you can refine these processes is if you study them. Are they working? Where's the breakdown? What do you got to do to maintain it? We replicated it so that our friends in Odo said, hey, we want to do this for tonsillectomy. And their results were even better than it was for general surgery. Then craniofacial wanted to start using it for some of their procedures. And then the hospital lost interest, and there's no follow-up with any of this stuff at this point. So we don't know if it's being sustained. It's our sense that other surgical programs have taken on the standardized treatment protocol, but there's no evidence that people are discussing pain prior to surgery. Okay. Now I'm going to tread on some thin ice and start talking about some of the research that's been published by Dr. Stevens in this area, because she talked about the general issues but did not get into her work. And what you will see is how she took a lot of what she talked to you about and actually studied it. So one of the early papers I found by Dr. Stevens' group focused on the idea of appreciative inquiry. And what's important here is that you're getting people to participate and collaborate. And there's this 4D cycle that you do with people where you're really trying to get their input. So it's discovery, it's dreaming, it's designing, and then it's strategies to help move toward that ideal. And taking that, then came the work on, I don't know why I'm presenting this, but
Good job.
thank you. Bonnie then elaborated on what some of the challenges are with using KT specifically for pediatric pain. And so some of the critical elements that you heard her describe were very, very well presented in this paper. And I have all of my references at the bottom if you want to go and get these things and learn from them. So the first thing that you really need to do is understand what's going on locally with pain practices. And then once you understand that, you could begin to use the evidence that's out there to try to improve the situation. What you heard Bonnie talking about in her presentation earlier was the issue of context. And I cannot agree more. And what you'll hear in the latter part of my talk is some of the factors of context that one has to look at. But clearly, you need to consider where you are trying to do this. What's going on there? Who are these people? What kind of climate is it that you're dealing with? And then the last step is actually facilitating that change. How you get people engaged, how you get people on any given unit to actually start to take what you're offering and implement it. So this was the CIHR study data where evidence-based practice for improving pain quality was studied in 16 different units in 8 hospitals. So again, high external validity, a well-designed study. And what you see in terms of some of the results is that people used validated pain assessment instruments more, a greater proportion of patients who got the medications and the physical pain management strategies that were advocated. Pain intensity scores went down, and overall the probability of patients experiencing severe pain dropped 51%. And 36 months later, those changes were sustained. So without completely seeming like I'm kissing up to my friend Bonnie, that's a good outcome, and that's a well-designed study. So I want to shift gears now and get a little bit more into what some of the barriers are. So Bonnie did a study that was controlled. She obviously had buy-in from the organizations that were doing this. But if we're clearly faced with the problem that guidelines don't seem to be embraced and implemented, what do we got to do to change that? Where are some of the inroads that we could make? So this was a paper that was published that looked at a whole bunch of other papers and identified some of the barriers. So the obvious ones are, well, people aren't aware that the guidelines exist. Or if they're aware that they exist, they haven't really read them and understand what's in them. Oftentimes people don't agree with the guidelines. Yeah, I know, that's what those guys said, you know, the quote-unquote experts, but I know better, I've been practicing for 18 years. People believe that their own self-efficacy is greater than any other guideline that could be handed down to them. The ability to overcome inertia, to just get the ball rolling and get people to do things differently. And then the absence of external barriers. So what you heard Stefan talking about as he went to implement his needle pain initiatives was, what are the barriers? How do you identify them? How do you break through them? The organizational context is often found as being a very significant issue. There's oftentimes financial disincentives for doing things differently. When I've talked to pediatricians in the past and asked them why they don't use topical anesthetics in their office, one of the first things they say is, well, it's cost. And that's not really the issue, but they perceive that oftentimes there's lack of reimbursement for doing the stuff that one might do to change practice. Organizational constraints are not trivial. If you're going to do something that's going to cost people more time, it ain't going to happen. So you really need to be respectful of how people approach their work. Perception of liability, like any kind of formal complaints, adhering with patient expectations. Oftentimes patients and families will come in and express their wishes related to a certain outcome, and if the guideline doesn't include that outcome, you're upsetting them. So for example, people come in, they want you to give them an antibiotic, and you say, I'm sorry, clinical practice guidelines stipulate that an antibiotic's not indicated here. They're upset because they want to leave with a prescription for an antibiotic. The social context is significant. What's the current standard of practice in that organization? What are the usual routines? How do you break those usual routines? Opinion leaders is critical. And I think Stefan alluded to it and the data show it, that you need to go in both directions. You need to have people in the trenches, especially the naysayers, who come around and say, no, we need to do things differently, as well as top down. How do you get past obsolete medical training? So I still get referrals in the pain clinic that this kid's got abdominal pain. We've scoped them from both ends. We've done the barium swallow. We've done the motility study. It's all in the kid's head. Go see the psychologist. Okay, when did that model die? In my humble opinion, somewhere between 1989 and 1992. Still the most common perspective when you're dealing with gastroenterologists and others. I don't want to just pick on them. Advocacy. So what are your competing forces? So I think,
Can you
again...
explain that? I don't think I understand what you just said. Like, where did what die?
The dichotomous model that pain is psychological or physiological, that it's one or the other.
And that you died and now people see it together, is that what you mean?
Yes. I think those of us who do chronic pain are constantly looking for an integrated model of unifying physiological and psychological, not the either or. Sorry, I took that for granted. That's not to say psychological factors are irrelevant and physiologic factors aren't irrelevant. It's just getting away from that strict dichotomy of pain being real versus in your head. Thanks for asking. Advocacy is an interesting one. And I think that, again, looking at the opioid situation, one of the things that happened there was drug companies became extremely aggressive marketing their products. So you had these detail people going out to general practices saying, oh, you could use this time-released opioid, not with a specific product in mind, to treat whatever kind of chronic pain. You're not going to put the person at risk for opioid misuse. It's time-released, etc. And if that's the person who's showing up at your office, giving you samples, buying you lunch, they're going to influence your practice, even if there's a guideline that may say otherwise. Knowledge and attitudes, the bigger context professionally. What happens when you're not so certain about whether or not a patient's presenting problem fits those guidelines? Are you more or less likely to adhere to it? Some of the stuff gets repetitive as you go through these papers. Again, the sense of competence, my skills are the ones that carry the day. Oftentimes people have a need to do something. Like a patient comes in, you have to do something, as opposed to just offering reassurance, when in fact there's not any standard treatment that may be so ideal. And the whole issue of information overload. Like how many, and especially in 2017, how many emails do you get a day on something related to your practice, right? And a lot of them may be relevant, but you're going to hit the delete key because you just can't possibly consume all that's out there. So what makes it more likely for a guideline to be adopted? So the first is obviously evidence-based as opposed to people's opinions. If things are based on hard evidence, that's sort of a necessary but not sufficient condition to get buy-in. There needs to be a relative advantage to the new process. If you're offering somebody a way to do things differently, it needs to make their lives somehow better. Either they're getting better outcomes, their job is easier, etc. If you come up with a guideline that's completely incompatible with people's current views, you're not going to get very far, so compatibility is important. If a guideline is complex, you're not going to get very far. The simpler, the better. Like if you're just doing a few critical things differently rather than trying to completely revamp people's processes. Trialability, it's an interesting word, but basically what that boils down to is, hey, can I try this on? Can I try this practice guideline and see if it resonates with me rather than having the whole thing pushed on me wholesale? Excuse me. And what about observing? Can you actually see what happens if people implement these guidelines? Can you understand the implication of it if it's actually been done? You want concrete descriptions of the desired performance. Not just you need to care more about your patient's pain. No. You need to use this instrument to systematically evaluate your patient's pain, and based on the findings, you need to engage in the following behaviors. So the more you can actually define and measure the concrete behaviors, the better. The nature of the health problem matters. These things are much easier with definable acute problems than they are with lesser defined or chronic problems, which is why the data on psychiatric interventions ain't so hot. Who are the healthcare professionals? Some people, based on discipline, are more likely to gravitate toward embracing data than are others. What about the setting? So you'll notice in some of the studies that I talked about, the centers that have higher volume, that see more patients, are those that tend to be more likely to adhere to some of the guidelines, as opposed to somebody who's got a general practice with 1,008 things going on. They're going to be less likely. If you start introducing a whole bunch of new skills or wholesale changes to the organization, not likely. Small incremental changes with guidelines are the ones that tend to be more likely to lead to success. What incentives are you giving people for adhering to guidelines? Are you going to pay them? And certainly in our organization, and I heard Stefan say it, if you're at a high management level and you implement a process change, if you've got data to show that that process change is happening, you get a bonus. And if it doesn't happen, you don't get a bonus. And some of the cynics in my organization, like me for example, thinks that one of the reasons that the organization decided not to do pain anymore is it's too hard. The VPs weren't getting their bonuses, which is a sick thing to say. But at least one senior vice president told me that's why I got dumped, which left me moderately irritated. Are there legal incentives? So in the state of Washington, they put a law into effect about opioid prescribing. So if you're prescribing more than 120 milligrams, and it's now down to 90, you must, by law, get consultation with a chronic pain specialist. So if you don't, you're going to be in trouble potentially with the licensing board. So all of a sudden, a whole bunch of people in general practice just stopped seeing people who had high opioid requirements because they feared the legal ramifications. Other kinds of regulation. Patient factors. If you're talking about more difficult patients, you're going to be less likely to get there. So again, there's a lot of strategies for how to increase acceptance. And Bonnie alluded to a lot of these, and these are just a list of some of the studies that have showed specifically if your intervention is multifaceted, you don't want to just educate, you don't want to just do one element, you need to have multiple facets to what you're doing. Interactive education is far better than passive learning. So if what you do, I'm sorry, I'm wondering again. If what you're doing is you go in and give a grand rounds on doing things differently with pain, you may see behavior change for a week or two. But when you actually then work with people, and the studies where it showed specifically strategies where residents were working side by side with attendings implementing these kinds of guidelines, you had better outcomes. Interprofessional collaboration and communication. So I don't know what it's like in your environment, but if there is an innovation in our organization that comes up through nursing, I will pretty much guarantee you the medical staff will not adhere to it. It's a nursing issue. So when we put together our interdisciplinary committee to look at pain in our organization, I made very sure that there was a lot of physician representation on that committee. Otherwise, you're not going to get the buy-in. So making sure that there's collaboration and communication with physicians, nurses, child life specialists, etc., is going to be a critical key to success. Integrated training, I've alluded to. Clinical reminders. So with electronic medical records, you've got the opportunity more and more to have ways to remind people to do the right thing or make it easier for them to do the right thing. Giving them feedback on their performance, invoking rewards or awards. Like, you know, this is the best unit in the hospital, and it's got a big blue ribbon up in the nurses' station because they did so well with pain treatment. Social media, Stefan will talk about that for 4 hours anytime you want to get him started. It's important to keep your practice guidelines current. If you're trying to keep using a practice guideline and the field has moved on and people are going, well, this has no credibility, it completely ignores blah, 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 that would be a problem. And I would argue, because I'm a Mayday Fellow and this was my focus, consumer engagement is critical. If you get patients and families to understand and buy in to what you're doing. So again, these are just, as you go through the literature, you keep finding things that talk about strategies to make it more likely that guidelines will get accepted. A big one has to do with how do you disseminate them. A weak intervention is if you just do didactic stuff. If you actually get people where you're giving them feedback, auditing their practice, targeting specific advisors, getting key people in the environment to buy in and become an opinion leader, those are things that are make it moderately effective. And some of the stronger interventions that people have found is specific reminders, academic detailing, which is again the idea that you've got somebody at your side telling you what to do, making it easy, etc. The detailing model came from our friends in the pharmaceutical industry, and needless to say, it made them a lot of money, so there must be some bang for the buck there. Dissemination and implementation, clearly, again, these are redundant because I pulled them from different sources, but you start to see some very, very clear trends with ways that people are trying to do this. And again, I keep coming back to things that involve patients, because I think that if we get them going, that's going to really change the ballgame a little bit. There was a Cochrane review on tools to facilitate the uptake of guidelines. So again, it's going to show a lot of the same issues over and over again. And very interestingly, what I got out of this Cochrane guideline more than anything else is how few really well done studies there are looking at these kinds of large-scale changes. So the critical ingredients in a nutshell is you need a commitment from leadership, you need a plan for how you're going to educate people, you need a systems plan where you've got objective measurements, you've got somebody who's looking at the data and giving feedback on the data, and there needs to be motivators for why people would do this. So the bottom line is that you're looking to change individual behavior. And this is where I have not seen some of the stuff that I'd love to see in this field. So Bonnie and I were talking about this during the lunch break. I firmly believe that ultimately what you're talking about is changing individual behavior. And individuals, even when they know the right thing to do, often will not do it. So I'm going to give you a simple example. Is anybody here a gambler? Anybody play 21 at a casino?
Ever?
Ever? Okay. So you go into a casino and you go, I'm going to bet $10 on each hand. And that's going to be what I'm going to do. And then all of a sudden you go, you know what? I got a feeling about this hand. I'm going to put in 20 bucks. Ever done that? It's a completely irrational, moronic thing to do. But people do it. Okay. So we have many, many examples across the board of people making bad decisions. And there are people in this world who actually study decision making for a living. There are ways that you could stack the deck to make it easier for people to make the right decision and implement it. Certainly in the business world, especially in the marketing world, these principles have been applied all over the place. Why is it that you go to Costco and you buy a bunch of stuff that you never need? Because it's sitting there, you look at it, you go, that's a good price, and you buy it. Why does that happen? Because some genius behind Costco's marketing figured out that if you make it appealing in a certain way, people will do it. Those tactics, the whole idea of nudge, which has been implemented again in the business world and in some governmental settings, how many people in this world have ever even heard of nudge? One. Enlightened. Okay, so that's Dick Thaler. He's probably going to win the Nobel Prize for economics at the University of Chicago. None of this has infiltrated the world of medicine, and what I'm hoping is that someday it does. And with that, I think I'm over my time, so I'm going to shut up. Thank you. Anybody have questions or comments? Bonnie.
So I'll just make one comment. It was in regards to the incentives. And at our institution, pain was, for 2 years in a row, was set as an organizational priority. And the CEO and VP's compensation was attached to whether or not that priority improved. So they had clear goals, etc. And we were all horrified by that, thinking that, you know, they would gain money as to whether we did better pain management or not. But after 2 years, they thought they'd done enough, had enough attention on pain, so pain wasn't a priority anymore. And all of our outcomes went down. When it wasn't a priority that was attached to executive compensation.
Yep.
So even though it's something that you think, oh my God, this is a terrible thing, and it was very visible, like everybody knew about it. We all had this sort of knee-jerk, this is a terrible way to go. It was amazing that when that finished, all of the, not all, but many of the achievements that had been made stopped.
So I I hear you, and that's exactly what happened in our organization. When it was a hospital goal, it was being incentivized, and we made some very significant inroads. And when it's not, all of those things, available data would show that they're not being done to the same degree. And I could see where from a purely business standpoint, like if you're in the business of running that hospital, and you've got outcomes that are especially going to have impact on cost, it's a very reasonable thing to do. Like if you're a clinician, it's antithetical to how we're trained, right? You should be doing these things because it's the right thing to do for patients. But if you get really actuarial about it, he uses that word on purpose, when you get really actuarial about it, that's how you create the change, is that you incentivize people in an appropriate way.
Would you suggest then that that doesn't imply a cultural change? That it's,
That's how you get
So
cultural
I
change.
Well, I mean, but then.
But it's not
it's-
sustainable.
The
Sustainable.
issue that we didn't talk about is sustainability, just as you're saying. So, I mean, we talk so much about behavioral change, increasing your knowledge, improving attitudes, all of these kinds of things, decreasing error rates. And we have lots of knowledge about how to get to those outcomes. But there's a whole science around sustainability as well. And I think that's what we really need to focus on. And outcomes aren't seen to be sustainable unless you sustain them for at least 3 years. So if you start to see things sort of sliding back towards baseline, obviously you have to engage some strategies to sustain them. And that's really, I think, Stefan talked about it and you talked about it, really ensuring that the change becomes part of the fabric of the institution, so you don't think about it anymore. I mean, I always use the example around vital signs. Like, you don't have to tell nurses ever that they have to do vital signs once per shift or every 4 hours or whatever, because that's so much part of just what they do. They don't think about it anymore. And I think that's where we have to get to with pain.
Agreed.
Bonnie, can I ask you, do you think it'd be more effective to incentivize the CEOs and VPs in the hospital or the nurses and the physicians on a ward based on Press-Ganey scores or something like that?
We try to incentivize them all the time,
I
but
mean, with money, I
we
mean,
don't have.
financial bonuses.
Yeah. Well, I mean, that's what happens in business, right? And business is very successful with that approach. In healthcare, we tend to do little things, like we buy them pizza, or we, honestly, if I want to change, if I want people to come to an event, I get interesting food there, and they come in droves. But that doesn't sustain things over time. And I'm not sure whether, if you could give a financial bonus out. We gave parking vouchers once, that you got to park in the executive spots if you did a really good job around pain management for that month. And that was really, really popular. So it's getting at what's important to people.
I guess what I'm asking is not the nitty-gritty of what you give, but instead of giving, multi-tens of thousands or whatever, $100,000 bonus to the VPs or to the CEO, why aren't we giving? Wouldn't it be more effective to give a monthly financial bonus based on Press-Ganey scores to the best unit in the hospital?
So it's even simpler than that, because Seattle Children's does do that. So they instituted this program to improve provider-patient relationships with strategies like how you welcome a person to clinic, introduce yourself, ask them what their goals are, thank them for coming, make sure that you make it clear you've reviewed their medical records, etc. So they took the Department of Anesthesia, for example, and they said, we want 80% of the providers in your department to go through this training. If they do, then everybody in the department is going to get X hundred or whatever dollars for doing that. If you meet your stretch goal, it's going to be even more than that. Well, don't you think there was a ridiculous amount of peer pressure to say, hey, Elliot, have you done the training? We want you to do the training. And it works. Now, the next question, of course, would be, does it translate into what goes on in the exam room with patients, or when you're getting consent from a family before going into surgery, which is a different issue, but at least the idea of incentivizing the people who could really implement the change is being done in some places.
And,
Alan,
uh,
I feel like Phil Donahue.
Yeah. I,
That's an age-related.
Yeah, I know.
I was just going to ask whether it really does work in businesses, because you see all sorts of companies that fail while their CEOs are getting gazillion-dollar bonuses for going downhill as a company. When we were doing our project in Thailand, we designated 1 or 2 nurse facilitators in each unit in the hospitals we were working with, who got some extra training, and some, were supposed to be the champions, and gave them a bonus or an extra salary because we felt they were putting in more time. And at least 1 or 2 of the hospitals, the nurses who received that bonus took the money and used it to buy toys for the playroom in the hospital instead of themselves, which, when you consider they're probably making about $40 a month, was pretty impressive.
Linda, would you want to talk about the business?
I don't think it's, in business, it's generally not an either-or kind of thing, because the problem is that I think it's very good to give people bonuses as long as they can control their ability to make the bonus. And you can't give it to the nurses and take it away from the people in the executive staff who control the resources the nurses would have to use. So that's the way it works best in business, when you have it on both levels. And most of the businesses I've been involved with, they do have, especially in the tech industry, they do have it on both sides. What's interesting is, in the tech industry, a lot of it tends to be monetary at the lower level and piece of the company at the higher level. So you'll see when they say Jeff Imhoff from GE got $24 million in compensation last year, he really only got $500,000 in a salary, or $1 million in a salary, and all the rest were in stock bonuses.
It's $1 million, no, that's nothing.